Welcome to the Virulent Vortex, a podcast in which we discuss infectious disease across scales, from pathogens and molecules to populations, pandemics, and everything in between. My name is Jaap de Rode. I'm the host of this show, and I'm a biology professor here at Emory University. And with me today is Rachel Pearson. Rachel is a graduate student in the Immunology and Molecular Pathogenesis graduate program. Rachel, welcome to the show.
Thank you for having me.
All right, so I already mentioned kind of what you're doing. So you do immunology, you do TB, you do HIV. Mm-hmm. Tell us a little bit about what you're trying to find out.
So I study immune response in people with HIV. And that immune response is CD4 T cells. And so T cells are a part of the immune response that really help protect ourselves against different viral infections and bacterial infections. So I'm interested in looking at those immune responses in people with HIV. And then in people with HIV, there's also common infections such as tuberculosis. And so that accounts for approximately 1/3 of HIV-related deaths. So it's a huge global impact on people with HIV. And so specifically, I'm looking at CD4 T cell immune responses in people with HIV.
So these are individuals that have both HIV and TB. And so now to remind us, so HIV is a virus that actually infects immune cells.
Yes.
Are those the same immune cells that you're studying?
Yes. So HIV does infect CD4 T cells. It doesn't infect every single one of them in the body, but quite a few. And when people are on treatment for HIV, which is called antiretroviral therapy, they suppress the viral load. So there aren't actively infected cells in the body, but they are affected by HIV infection irreversibly.
Right, because the HIV virus is kind of taking away some of the arsenal of defensive cells that the body has.
Correct.
And so these same T cells are also involved in immunity against tuberculosis?
Yes. So CD4 T cells, we think of them as T helper cells. So they help the immune response and kind of coordinate immune responses following infection. And CD4 T cells are specifically and particularly good at combating bacterial infections. So tuberculosis is caused by a bacterium called Mycobacterium tuberculosis. So it's really good at combating that infection with TB. So it's a combination, like a perfect storm here, where we have HIV in these individuals that affect their CD4 T cells, and then we need those CD4 T cells to then combat TB that prevents progression to TB disease.
Right. So you're using existing individuals that have HIV and TB, and then what do you do?
So I particularly follow a cohort of individuals in Mombasa, Kenya. These individuals are women that are female sex workers, and due to their behavior, they're at high risk for HIV infection. And so they're enrolled in this study, and they're followed over time, and they're tested for HIV at monthly follow-up visits, in which we can tell around about exactly when they become HIV infected. And this is really unique cohort of individuals because you don't normally have blood samples from people before they're infected with HIV. You don't go to the doctor and just randomly give blood and they biobank those samples. That doesn't normally happen. You have to have funding for that. And so this is really unique to look within the same individual before HIV infection, after HIV infection, and then before and after treatment.
Right.
So it's really interesting and cool.
Yeah, that's really interesting. Kind of sad too to know that you're studying people and you see it happening, but you must feel kind of powerless to prevent it, right?
Yes, and that's part of why I do what I do, because it affects so many people. Like these individuals, like obviously we're not giving them HIV infection just from their life. They've acquired it, but it is a unique opportunity to study this. So yes, it's very sad for these individual people, but hopefully they can help reveal more information to help therapies.
You get the samples so you can really measure these T cells over time, these CD4 T cells. And do you then also, do these same individuals also get TB at the same time? So
the proportion of people that are infected with TB or have been infected with TB is about like 99%, at least greater than 90%. in this area.
Yeah.
So what I found so far is that in those people, the same individuals, after HIV infection, these really important CD4 T cells have different populations. You can call them different like subtypes, different flavors of CD4 T cells. And so in those CD4 T cells, there's what we call T helper 1 cells and T helper 17 cells. And those are really important in combating TB. And in these people, once they are infected with HIV, those populations of CD4 T cells are depleted.
Yeah.
And so they're really the immune control that the T cells can give to help combat TB is very hindered after HIV infection. Yeah. And then furthermore, when we look at people who've started treatment earlier after HIV infection, so they acquire HIV and within 6 months after infection, they start treatment. Yeah. Those important populations of Th1 and Th17 cells rebound and are recovered. Yeah. But in people who start the treatment greater than 1 year after HIV infection, those populations are not rebounded. We don't see that effect at all. So it's really important to be diagnosed early because a lot of people go around not being diagnosed. And so you have like that 6-month window of being able to preserve those populations. And it seems to be irreversible where if you start it later, you don't get those populations back.
And so the other thing I was wondering, just listening to you while you're describing your results, is that if you screened people very regularly, so you could be within that 6-month cutoff period, would that be another way that you could say, hey, my data tell us, test everyone regularly, and as soon as you see this HIV, you have to start treatment because that at least will prevent them from having these serious negative effects toward losing their cells that protect against TB?
Yes, absolutely. I think that's definitely something that this reveals. And the World Health Organization right now, like when you're tested and you become positive, you immediately start treatment. But you hinted at a very important problem, which is, okay, then you need to be tested. Yeah. You need to actually know you have HIV infection to preserve those important populations of CD4 T cells.
And I was just wondering about this testing. So a lot of us now are, with the COVID pandemic, of course, testing has become either you go to a clinic and you have a PCR test, or you can have these home tests at home that are very easy to use. Is that not possible for HIV?
It's a really good question. I'm not sure the answer. It might be possible, but I know that the testing that they do in the clinic generally looks for antibodies to HIV. So that's called seroconversion. Yeah. When you have antibodies that, are specific for HIV, then you're HIV positive. Yeah. So theoretically, it's possible to develop a test. I don't know the specifics about that, but we have other like ELISA type tests or antibody type tests where it can see whether antibodies are there or not. The problem is it's not a nasal swab. Problem is you need the blood.
Right. Well, Rachel, it was really wonderful talking to you, learning about your very fascinating work on the co-infections between TB and HIV and the role of the immune system in there. We hope you enjoyed this episode too, and we look forward to seeing you again. Thanks for watching.